Hello, everyone. My name is Dr. Selma Mohammed. I'm a professor of medicine, the Division of Cardiology at Creighton University, and the director of Heart Failure Program at Creighton University and CHI Health in Omaha, Nebraska. I'm super excited to welcome you today to our Heart Failure Society of America Heart Failure Patient and Caregiver webinar, Heart Failure and Obesity. This webinar is presented by the Heart Failure Society of America, HFSA. We're very proud to offer this educational opportunity as part of our mission to advance heart failure care. First and foremost, I would like to recognize and thank our sponsors, Merck, Abbott, AstraZeneca, Novartis, and Novo Nordisk. And please remember to visit their virtual sponsorship booth. So, overview of our program for today. Today will be treated to presentations by heart failure physicians, Jennifer Thibodeau and Justin Vader. They'll provide valuable insights into how excess weight can increase the risk of developing heart failure and how effective weight management can positively influence outcomes. It's intended to provide attendees essential knowledge and actionable steps to promote a healthier heart and improve quality of life. We'll take questions and answer from the questions section to present to the speakers at the end of the two segments. Please don't forget to put your questions in the questions section of the chat box. At the conclusions of the webinar, participants will receive a survey link. We encourage you and will be very grateful if you could please complete the survey, as it helps the Heart Failure Society of America improve programming for our patients and caregivers. And I would like to introduce our first speaker, Dr. Justin Vader. He is a professor of medicine in the Cardiovascular Disease Division at the Washington University in St. Louis, Missouri. He also serves as the program director for the Advanced Heart Failure and Heart Transplant Cardiology Fellowship and the Heart Failure Service Line director for the Barnes-Jewish Hospital. Dr. Vader is a fellow of the Heart Failure Society of America. He has served in several capacities, including his current role as a co-chair of the 2025 HFSA Annual Scientific Sessions. He's also a guest editor at the Journal of Cardiac Failure. Welcome, Dr. Vader.
Thanks, Selma, and it's my pleasure to speak today on some background information about heart failure and obesity. And I will be happy to hand things over to Dr. Thibodeau to bring things home and give a little bit more of the contemporary data, particularly with regard to pharmacotherapy. I'd like to just start a little bit with definitions and what is the definition of obesity. So the World Health Organization defines obesity by body mass index, and a body mass index of over 30 kilograms per meter squared is defined as obesity, with class 1, class 2, and class 3 obesity ranging upwards from 30 to 35 to over 40 kilograms per meter squared. There are other pertinent measurements that are used to measure whether a patient is obese or if their body mass index is merely elevated, and those can include waist circumference, so a waist circumference of over 35 inches, a waist to height ratio of over 0.5, and then a waist hip ratio of over 8.5 in women and over 0.9 or 0.85 in women and 0.9 in men. Please understand that these are normals that are derived predominantly from European data sets, and there is considerable literature about whether or not this is applicable across the world. Whenever you do apply the simple definition of body mass index of over 30 kilograms per meter squared, you get over 40% of the United States population. So you can see how this is a large issue when we speak from a public health perspective. Now, when we talk about the clinical relevance of obesity, the Lancet Diabetes and Endocrinology Commission is a useful tool for looking at what drills down to clinical obesity. So there are three different terms. One is excess adiposity. So that's an elevated body mass index plus one of the additional measures that I mentioned. There's preclinical obesity, which is excess adiposity plus preserved organ function. And then there is clinical obesity, which is excess adiposity and organ dysfunction of some sort. What are the sorts of organ dysfunction that we're speaking of? The list of associated comorbidities that goes with obesity is a long list. It includes type 2 diabetes, hypertension, hyperlipidemia, sleep apnea, fatty liver disease, osteoarthritis, depression, and certain forms of malignancy. As you can tell from this list, there are a number of conditions that have direct or indirect implications for the heart. Now let's step back just another step and we'll talk about heart failure from a more global perspective. The Universal Definition of Heart Failure, published in 2021 in the Journal of Cardiac Failure, gives us a basis for defining what is heart failure. And that is signs and or symptoms of heart failure, which include symptoms such as breathlessness, fatigue, exertional intolerance, caused by structural and or functional cardiac abnormalities. And this should be corroborated by some measure of elevated cardiac filling pressures, such as elevated natriuretic peptides, that's blood work, or objective evidence of cardiogenic or systemic congestion by either invasive measures through catheterization or non-invasive measures through echocardiogram. We can further divide patients with heart failure into patients who have reduced left ventricular ejection fraction, or HFrEF, preserved left ventricular ejection fraction, or HFpEF, that's an EF over 50%, and those that are in between from an EF of 40 to 50%. Along the spectrum of heart failure, the ACC and AHA have stages of heart failure, which are at risk, stage A, pre-symptomatic, stage B, symptomatic, stage C, and then advanced, stage D. So for the purposes of this discussion, we're going to be talking about patients predominantly who are pre-symptomatic or symptomatic, but I will also touch on advanced patients in this conversation. So sort of back to this interaction between obesity and heart failure. You see from this illustration from Circulation in 2021 that there are a number of different biologic pathways that can converge upon the heart. These are some of the pathways that those of us in the heart failure world recognize very well. This can include activation of the sympathetic nervous system. This can include activation of the renin-angiotensin-aldosterone system. It includes metabolic alterations that either directly or indirectly affect cardiac myocytes and cause dysfunction of myocytes. And then there are a number of factors that have to do with respiratory mechanics that can alter the mechanics, in particular the right ventricle and the pulmonary circulation. Again, all of these can converge to generate myocardial dysfunction and the syndrome of heart failure. Now, as to what the implications of obesity in patients with heart failure are, we do need to recognize that there has been described what is the obesity paradox in heart failure patients, particularly in patients with heart failure and reduced left ventricular ejection fraction. The figure that you see on the left here shows the hazard or the relative risk for complications from mortality, cardiovascular mortality, and hospitalization with regard to patients who are low BMI, overweight, obese, or severely obese. And you can see that there is a greater hazard of complications for patients that are actually at low BMI or underweight relative to patients that are overweight or obese. And for the severely obese patient class, there may be another inflection upwards for complications related to patients who have heart failure and obesity. And this may come as a somewhat counterintuitive observation, and it is a little bit complex to get into. Obesity, we know in heart failure patients, is associated with lower exercise capacity, lower quality of life scores on symptom inventories, and increased hospitalization. Obesity measures alone may be inadequate to capture the true metabolic complications related to excess adiposity. And sometimes there are confounders that are mixed into these data observations. I think we should state that unintentional weight loss in patients with chronic heart failure is oftentimes a bad sign. And there may be external considerations that play into our deliberations about trying to encourage patients to lose weight, such as eligibility for therapies like transplantation or LVAD. And as is commonly said, more data on obese patients with heart failure and reduced ejection fraction, particularly the effects of weight loss on those patients, are needed. What about whenever we're talking about approaches to managing obesity and heart failure? This graphic shows the three major attitudes towards how one might achieve weight loss: behavioral change with diet and exercise, anti-obesity medications, which you'll hear quite a bit more about from Dr. Thibodeau, and then metabolic and bariatric surgery. And I mentioned them in essentially ascending order of efficacy in terms of magnitude and maintenance of weight loss. Let me delve into these a little bit more. I would say that the strongest evidence for the use of exercise and prevention of complications related to obesity is really in the preventative stages before the onset of heart failure. These data show that, in particular, for prevention of heart failure with preserved ejection fraction, leisure time physical activity, so physical activity, is associated with lesser hazard for heart failure. And so this is certainly a case where an ounce of prevention is most valuable. With patients who have established heart failure, dietary modifications are often recommended, but this can be challenging. Combined dietary and exercise interventions in patients with established heart failure may result in about 5 to 10% weight loss per year. There are beneficial effects on cardiovascular markers and functional status, but maintenance can be challenging. The strongest data are in patients with heart failure and preserved EF, and it is currently not truly well established what is the best dietary intervention to achieve this weight loss, with many people advocating for preservation of protein calorie intake in the diet to prevent cachexia and muscle loss. Exercise has an established role in heart failure with reduced EF for sure. Data from the HF Action trial tell us this, and in fact, it's an approved indication for cardiac rehabilitation. There's less rigorous data in heart failure with preserved EF, but there are emerging data in clinical trials that apply to this area. Certainly, medications have a role, and I won't get too deeply into this. I'll let Dr. Thibodeau get deeper into the data, but the history of medications for obesity and heart failure patients has been challenging, including a number of agents that you see on this graphic highlighted in red: fen-phen, sibutramine, lorcaserin, which were removed from the market due to complications related to cardiovascular disease or other issues. What are the targets of intervention of these drugs? Many of these are the brain, but some of them are also the gastrointestinal system. And in particular, the newer agents that we will be covering tonight include the GLP-1 receptor agonists that affect both the brain, the GI tract, and metabolism by virtue of insulin production by the pancreas. These medications can have an important effect on weight loss, but I would say that the most powerful therapies for losing a large amount of weight remain surgical therapies. As you see, sleeve gastrectomy shown here in terms of average weight loss from baseline, 25% compared to all of the other medications arrayed on the bar below. The invasive therapies for weight loss and heart failure include Roux-en-Y gastric bypass, the most comprehensive, which results in 30% weight loss at 1 year and 70% maintenance at 10 years. Gastric sleeve somewhat behind that at 23% weight loss at 1 year and 18% maintenance at 4 years. There are other laparoscopic interventions where may have slightly lower degrees of weight loss, more in the range of 15%. It should be said that bariatric surgery in a preventative measure has been shown to reduce heart failure risk and improve cardiac structure and function. In patients with established heart failure, it has also, in non-randomized data, been associated with fewer heart failure events. Now, one must realize that heart failure patients are at increased operative risk compared to non-heart failure controls, perhaps 2 to 3 times higher risk. But this is certainly a case for selected high-risk, high-reward settings, and instances of this have included large weight loss to make people eligible for therapies such as cardiac transplant. So I'll conclude my section with a few take-home points: that obesity and heart failure are both prevalent and therefore overlapping diagnoses, that obesity increases the risk for heart failure with preserved EF, in particular over heart failure with reduced EF, that prevention is a better evidenced situation than post-heart failure diagnosis intervention for weight loss, and that an obesity paradox exists in heart failure with reduced EF, and it certainly justifies individualized care. Surgical and medical interventions can certainly increase weight loss success over diet and exercise interventions, and I will let Dr. Thibodeau delve into more of the pharmacologic interventions in her section.
Thank you so much, Dr. Vader. That was just such an outstanding overview of the background, approaches to therapy and surgical treatment for obesity and heart failure. Before we go into our next session, I would like to remind our participants to post questions in the questions section for the Q&A segment. Next, I'm going to introduce our next speaker, Dr. Jennifer Thibodeau. She's a professor of medicine. She's also the medical director of heart failure and the medical director for extracorporeal membrane oxygenation, or ECMO, at the University of Texas Southwestern Medical Center. Dr. Thibodeau has clinical expertise in advanced heart failure, cardiac transplantation, and ventricular assist devices, and is particularly interested in hemodynamic assessment of symptoms of heart failure and physical examination for heart failure. Dr. Thibodeau is going to talk to us about contemporary therapies of heart failure population with obesity. Welcome, Dr. Thibodeau. We'll just ask you to unmute yourself, please.
Yes, sorry. Am I unmuted now? Does that work? Okay, good. Sorry about that. So Jenny Thibodeau, and I'm happy to be here and to talk with you guys and educate you a little bit about how we treat obesity, and specifically how these medications that we use to treat obesity can be used for people who have heart failure. As Dr. Vader mentioned, the previous medications that had been used for weight loss really didn't work very well at all, and actually were not so safe for people who have heart disease. And so we don't tend to use any of these medications any longer. And up until recently, really the only thing we could do to treat obesity was surgery, most commonly the sleeve gastrectomy or gastric bypass. Certainly, we'd love to be able to do things that are less invasive, including medications, in order to help people who have obesity to lose weight. And so recently, we've been able to look at some of these drugs, the GLP-1 and GLP-1/GIP receptor agonists. I was originally going to call these the super drugs. You know, Superman just came out, but then I realized that women are actually pretty awesome too. And so I changed my slide to include some superheroes that are women, and these can now be our wonderful and marvelous drugs. And we will talk about these wonderful and marvelous drugs moving forward. So what are GLP-1 and GIP receptor agonists, and how do they work? Well, GIP, or we'll call them GLP-1 and GIPs. The GLP-1 agonists mimic the way that a hormone that's called glucagon-like peptide 1 works in the body. So when sugar starts to increase after you've had a meal, after you eat a snack, these medicines cause the pancreas to make more insulin, which helps to lower sugar. And so the GLP-1 agonists also help to make more insulin and lower sugar. It also blocks glucagon secretion, and glucagon is a hormone that the body uses to raise sugar when necessary. So we can block that with these medicines to decrease the amount of sugar in the body. And so through those actions is how these medicines work to help with diabetes. These medicines also work to slow the digestion and movement of food from the stomach through the intestines. And that slowed digestion helps to decrease the spikes that you see in sugar after you eat. It also makes people feel full faster and stay full longer, so people end up eating less. They also work on part of the brain to curb hunger and make you feel full so that you also eat less. Tirzepatide is a GLP-1 receptor agonist, but also has GIP receptor agonist properties. And GIP is glucose-dependent insulinotropic polypeptide agonist. Say that 5 times fast. So the way that medicine works is it complements the GLP-1 receptor agonists by adding further appetite regulation by working on different parts of the brain. It also works directly on adipose tissue or fat tissue, which leads to the breakdown of fat and adds to the benefits of the GLP-1 receptor agonists. So altogether, these medicines work to reduce how much food people eat, keep the levels of sugar stable in the body, decrease your appetite and make you feel full longer, and all of that can lead to weight loss. Again, our wonderful and marvelous drugs. So the two main ones that we use for weight loss are semaglutide and tirzepatide. And this was a study that was done just recently that looked at how these medicines worked for weight loss over 72 weeks. So it looked at people who took them versus placebo. I'm sorry, this one looked at the comparison of the two. And the semaglutide decreased body weight by 13.7% and tirzepatide by 20.2%, and also decreased your waist circumference by 13 and 18%. So really significant, almost the same as what we would see with those surgical changes. So now if we look at that same graph with these two medicines that are now approved for weight loss, you can see that we're made a much better dent in weight loss here compared to the old medicines that we used to have. When looking at these medicines, but also medicines that are under development, You can see the green ones are medicines that we have right now that doctors can prescribe, and the blue ones are the medicines that are under production or in development right now. And then again, the orange is your sleeve gastrectomy, the surgery. You can see that we're really starting to approach the benefit that you could have with surgery. And in fact, a lot of people are now saying that we shouldn't even say that a drug should be used for weight loss if it doesn't give you at least 10% weight loss. So these medicines certainly do more than 10%. With tirzepatide is the current one that can lower weight the most, and retatrutide is in development, which is a little bit more. So the things that we want to think about when we think about medicines for weight loss and diabetes, because diabetes and heart disease kind of go hand in hand, is are they safe for people who have heart disease, including coronary artery disease or blocked arteries of the heart and heart failure. So what I'm about to show you is a meta-analysis of 10 different studies that looked at safety events. And the things that they looked at are what we call a 3-point MACE, which is 3 different major adverse cardiac events. Those major adverse cardiac events included death from heart disease, non-deadly heart attack, or non-deadly stroke. It looked at those combinations and then each of these separately. Death from any cause, hospitalization for heart failure, worsening kidney function in people who had diabetes, and then looked at some safety things. How often were people getting low blood sugar? Did they have problems with their pancreas? That was one of the initial concerns. And was there damage to the eyes for people who have diabetes called retinopathy? And then they also looked at different kinds of cancers. There was initially concern that this could cause some cancer. So it looked at all cancers and then pancreatic cancer and thyroid cancer in this meta-analysis of 10 studies. In this graph, if it's a little bit complicated, let me explain it to you. The left side is showing the 10 different studies that were evaluated. The thing with all the bars in the middle, if it's going to the left of that bar, then it's good for you. The medicine is good for you. And the right of the bar is what is the placebo, which was the fake medicine that didn't really do anything, and whether that was beneficial. And almost all of these studies showed that there was benefits. So there was a decrease in risk for death from heart disease, non-deadly heart attack, or non-deadly stroke. And when you combine all of that data together, there was definitely benefit with these medicines. When you look specifically for hospitalization of heart failure, because about 20% of the patients who were enrolled in these studies had heart failure, it also showed benefit for that. So people who were taking these medicines were less likely to be admitted to the hospital for their heart failure, which is also fantastic. And then this graphic kind of summarizes all of the things that they looked at. They saw that there was a 14% reduction in all of those major adverse cardiovascular events that we talked about. There was a 12% decrease in all-cause mortality, 14% decrease in hospitalization for heart failure, 17% decrease in worsening kidney function, and there was no difference in people who took the real drug versus the fake drug and any of the safety outcomes, including, like I said, the low blood sugar, the problems with the eyes, the problems with the pancreas, or any of the cancer concerns. So these medicines were safe and they had much more benefit compared to the fake drug. And so these were safe to use for people who have heart disease and heart failure. So now we can look at these medicines, and I have here on the left-hand side is the generic name. The second column is all the brand names that we use. Semaglutide is also called Wegovy. Sorry, I didn't put that one in that slide. And then how they were given is your third column. Most of them are injections, but there's now a semaglutide pill that you could take and what they're indicated for. So all of the ones that were studied for the cardiovascular disease benefits, I've now put that there. And then the last 4 are for obesity. I put a little squiggly line by liraglutide because it was originally approved for obesity. But as we saw in those slides, the amount of weight loss was really only 5 to 8%. And now with all these other medicines being so much better and people saying we really shouldn't say something's good for obesity unless it's more than 10%, I probably wouldn't classify it as a good obesity medicine now when we have so many other medicines that are better. So what about these medicines specifically for people who have HFpEF? What is HFpEF for one? So there are different kinds of heart failure. HFpEF and HFrEF are the two main. HFpEF is when your heart is contracting well, so it's moving well. So if you've got an ultrasound of your heart, what we call your ejection fraction would be okay. It's squeezing okay, but it isn't relaxing as well as it should. It's kind of stiff, and that's called HFpEF. We know that obesity is a risk factor for heart failure and other heart disease, and most people who have HFpEF also have obesity. So the question is that then will these medicines help HFpEF even if people don't have diabetes? So that's what the next couple of studies that I'm going to show you looked at. The STEP HFpEF and STEP HFpEF diabetes studies both looked at benefits of semaglutide in people who had had heart failure with preserved ejection fraction or HFpEF with and without diabetes. And the combined data showed that all of these patients lost weight, and they felt better when they looked at these patients and asked them different questions from a standardized survey. That's that KCCQ score is a standardized survey. And then the New York Heart Association classification, where we know how far can you walk or what your daily activities are before you get short of breath. They also found that people could walk farther. So they timed how far people could walk in 6 minutes. And those who used the medicine could walk more a longer distance in 6 minutes. And then also looked at heart failure labs, your NT-proBNP, and there was improvement with that for people who took the medication. They also then looked in Summit at tirzepatide and HFpEF, so another one of them, and found that those people who had obesity and HFpEF lost weight also, felt better also, using that same KCCQ survey. They again could walk longer distances in 6 minutes, and they had also improved kidney function, which wasn't looked at in the original study. And again, had lower risk of death from cardiovascular causes or worsening heart failure. As you can see here, the percent of people who had cardiovascular causes of death or worsening heart failure event was only 9.9% for people taking the medicine versus 15% for people who were taking the placebo or the fake medicine. So benefit here. So what can we say about these medicines in people who have HFpEF? We can say that it improves how people feel. It improves some markers of heart failure, like their lab work and how far they can walk. And it decreases the risk of death or worsening heart failure. So good for people who have HFpEF with preserved ejection fraction. What about in HFrEF? So in HFrEF, the problem is the opposite. The heart is not squeezing okay. So if we did an echocardiogram, your heart function would not be squeezing as vigorously as it was in a normal heart, but it might be able to relax okay. The original studies of liraglutide, which was the first of the GLP-1 receptor agonists that was approved, did not show benefit in heart failure, and actually there was some concern that it might be dangerous. It had people with faster heart rates, and they were going to the hospital a little bit more. So there was some concern we actually should not use this medicine for people who have heart failure. But there haven't been any trials that were looking at semaglutide or tirzepatide in HFrEF that were randomized studies. So randomized meaning that you take the drug or you have placebo. Those studies have not yet been done. What we do know are sort of some sub-analysis of studies that were done for all comers. About 1/4 of the patients in the SELECT trial had heart failure, either HFpEF or HFrEF. And again, they took the drug or they took the placebo. And they found that there was a decrease in the major adverse cardiac events of the non-deadly heart attack, non-deadly stroke, and death to the heart disease. And there was a decrease in cardiovascular death or worsening heart failure. And these benefits were the same for people who had HFpEF and HFrEF. So this is a little bit reassuring. We at least think that it can be safe for use in heart failure, but it wasn't designed specifically for heart failure. So we don't have that same solid data like we do for HFpEF. This was a real world study of GLP-1 receptor agonists in HFrEF. This was looking at a registry of patients with heart failure and looked at the safety of this medication for those patients in the registry. In this registry, in real world prescribing, saw that there was an improvement in cardiovascular death, particularly in people who are more obese, not just overweight, and especially people who had lower ejection fraction. So it could be that GLP-1 receptor agonists are helpful for HFrEF, but we just need to have more data. We don't have that data right now. So what can we summarize about these medicines in people who have HFrEF? We know that it will lead to weight loss and people might feel better, but we don't yet have enough data to say that it's beneficial from a heart standpoint for people who have HFrEF. So what if you're taking some of these other drugs? We know that SGLT2 inhibitors, particularly dapagliflozin or empagliflozin, also known as Farxiga and Jardiance, are very good for heart failure. So all of you who are listening, if you're not on one of those medicines, you should talk to your doctors or your providers and ask if that's something that would be helpful for you. We know that it's beneficial for people who have preserved ejection fraction and reduced ejection fraction. So if people are already taking these medicines, do we think that adding this other medicine on top of that is going to be helpful since we know how good those are? Well, we have looked at studies that looked at the benefit of these medicines, the GLP-1 agonists and GIP agonists, on top of SGLT2 inhibitors. And it is good to take both if they are both indicated for you. And this is a study that showed that. This was the SOUL study, and they looked at people who were taking the pill semaglutide and again, people in that study had a roll-in period, so not everybody was taking it. And actually more people in the placebo group were taking the SGLT2 inhibitors. But they found, again, that people who were taking both did better than people who were taking only the SGLT2 inhibitor or only the GLP-1 agonist. And then the gray lines are people who were not taking the GLP-1 receptor agonist, and they did worse. So if it's indicated, you should be taking both of these. They both have different benefits that are additive. So these medicines sometimes aren't easy to take. They do have side effects. And so when we start doing these medicines, we start off at low doses and then work our way up. And the side effects usually are nausea and diarrhea, which can happen very frequently. Ways to combat that or to get around that are to have small, frequent meals that aren't very rich or fatty. The rich and fatty foods are the ones that get you. So have small, frequent meals that are kind of the healthier foods for you. Also eat more slowly, because if you eat really quickly, remember that this is slowing all of your digestion. And so when you're eating very quickly, you're going to feel very full when you're done. But if you eat more slowly, you'll feel full quicker, but with less food. And then stop before you feel full so that you don't feel worse later on. And then, as I mentioned, we gradually increase the dose of these medicines over months. They also, when we have weight loss, in addition to losing fat, we can also lose a lot of muscle. And so one of the things that we have to make sure that we're doing on these medicines is that we eat protein-rich foods, because that's going to help you maintain muscle, and then do strength-based exercises so that you can continue to exercise your muscles and not lose them. Some people who have diabetes might have lower sugar if they're taking these medicines. And so when we start these medicines, we might decrease doses of other medicines being used to treat diabetes when we start them to prevent low blood sugars. And then finally, some people just are not so excited about giving themselves injections, and I don't blame you for that. There is now an option of oral semaglutide, and then another oral medicine, orforglipron, is being developed. The problem with this, which is another, you kind of trade one thing for the other, is that you need to fast at least 6 hours before and 30 minutes after taking these medicines for the pill to be absorbed. That's the biggest problem with taking the pill. So you have to make sure that you're doing that, and then you can take the pill and have similar effects. So in conclusion, we'll talk about who should be taking these medicines. Who should take the GLP-1 and the GIP receptor agonists? Well, anybody who has diabetes and has atherosclerotic cardiovascular disease, or ASCVD, or risk factors for that, who do and do not have diabetes. And that the cardiovascular disease includes people who've had a heart attack, a stroke, blocked arteries in their heart, disease in the blood vessels in their legs or their carotid arteries. And the risk factors might include older age with at least 2 of the following: obesity, high blood pressure, smoking, high cholesterol, and protein in the urine. So anybody who falls into these categories should be taking these medications. Similarly, people who are obese and have these same disease problems should also be taking these medicines, even if they do or do not have diabetes. People who have obesity and heart failure with preserved ejection fraction, I think we've got pretty good evidence that we should take this, that these are beneficial for that population. But we don't yet have good information for people who have heart failure and reduced ejection fraction. We know it's going to lead to weight loss. We know that people might feel better, but we need to get more information, especially in people who have advanced heart failure, if this is safe, and make sure that people are stable. But we don't have enough data to show that it improves heart failure outcomes. And then finally, my last slide, this was from a recent summary that looked at guidance for the community for people who are overweight and obesity and recommendations in heart failure. So if you're overweight and have heart failure, meaning that your BMI is between 25 and 29.9, there's no evidence that weight loss is beneficial, but we encourage a healthy lifestyle. If you have class 1 obesity, meaning that your BMI is between 30 and 34.9, then we do think that obesity treatment would be beneficial, particularly for HFpEF, and using GLP-1s can be helpful. Again, in HFrEF, we can individualize lifestyles, but we don't yet know that these medicines are going to be helpful. We have class 2 to 3 obesity, meaning that your BMI is over or equal to 35, then we do think that obesity should be treated for both HFpEF and HFrEF. Although for HFrEF, again, we don't yet know who are the best people that could be using these medications, and that really requires further study, and we will have more information, I'm sure, in the future. And that is all that I have for you. So we are now happy to take any questions that you might have.
Thank you so much, Dr. Thibodeau. That was phenomenal talk about obesity and contemporary therapies. So I'm going to start this off with our first audience question about obesity in the different types of heart failure. Is obesity a problem just in heart failure with reduced ejection fraction, preserved ejection fraction, or is it a problem for both?
I guess I could give a little bit of context to that, and I'd let Jenny follow on. I think certainly for patients with heart failure and preserved ejection fraction, there is both a risk function of obesity. So the more obesity early on in life, the more risk of developing heart failure with preserved ejection fraction. And then there's much more of a function of evidence where if you can reduce weight in heart failure with preserved ejection fraction, you can improve outcomes or symptoms, as in some of the clinical trial data that Jenny described from the recent pharmacotherapy trials. So I think that relationship is nicely established. It is challenging with heart failure and reduced ejection fraction, however, because there is less data about the benefits of weight loss in these patients. As mentioned, there's usually a report of improved functional capacity for obese patients who have reduced EF heart failure and lose weight. However, we sometimes become a little bit uncertain when it comes to large-scale weight loss, and especially if that weight loss threatens to mean muscle mass weight loss in patients who have reduced ejection fraction and particularly severe heart dysfunction, because that could be a sign of progressive heart failure. So it is an area that does call out for more data. I would say in practice, I encourage patients to lose weight down to a healthy weight. Jenny outline those sort of categories of obesity. And so patients that are severely obese, I certainly counsel to lose weight. However, patients that are minimally overweight, I don't tell them that they need to get down to a BMI of 20 for the mere purpose of being at so-called normal BMIs. It's a little bit challenging, but that would be my sort of summary of my approach to it.
Excellent. Thank you so much. Dr. Thibodeau, anything to add?
No, I think that Dr. Vader answered that quite well. The data for obesity in HFpEF is there. We don't have as much information for HFrEF. People do tend to feel better when they lose weight, so it is something to help encourage, but how we get to that weight loss, I think, is what we don't yet know for the HFrEF population.
Perfect. So we have a question about whether losing weight will help the patients take fewer medications. I think they're probably looking into medications for heart failure or medications for comorbidities.
Yeah, for heart failure medicines, I tell patients this all the time, the medicines that we give you are yours for life for the most part. So especially for HFrEF, when you take these medicines, and even if your heart function improves to a normal ejection fraction, we know from a study called TREAD-HF that if we take those medicines away, the heart function can get worse again in about 40%. And then if we give those medicines back, about 25% of people don't get the same improvement. So it's, at least with the data that we have today, the medicines that we give specifically for heart failure to help the heart stay stable are yours for life. You may be able to come off on some of the water pills, definitely some of the blood pressure pills if you're taking additional medicines for blood pressure, and diabetes might be much better controlled, and cholesterol might be much better controlled. So those medicines might be able to come down, but the medicines to help the heart stay strong are yours for life.
That's excellent. Thank you so much for clarifying, Dr. Thibodeau. So the next question that we have is asking about diet, and this is something that Dr. Vader has discussed earlier. The question is it a one-size-fits-all? You did mention some of the diet that could help with weight loss. So maybe you could just tell us a little bit about that, Dr. Vader.
The interventions of diet for patients who have heart failure is an area that I would say has been partly studied, but incompletely evidenced. I think the bottom line for weight loss has to do with reduced calorie intake, is sort of the bottom line. Most physicians, I think, would recommend diets that preserve protein calorie intake and eliminate things like highly refined sugars and things that are essentially metabolically disadvantageous for other reasons as well. There is no one single endorsed diet by the ACC or the AHA or the Heart Failure Society for weight loss in patients with heart failure. And so our most recent scientific statement guidelines do not have a single dietary recommendation. Most recommendations do sort of orbit around the areas that I had mentioned.
So I think that when you're going grocery shopping, the things to think about are the outside of the grocery store. So all of the fresh produce and vegetables and the meats and the dairy products that are on the outside, but all the processed food in the middle are the things that you're going to want to avoid. And then think about portion sizes to try to decrease portion sizes to encourage weight loss.
Yeah, I would echo, there's a author, Michael Palin, who his simple advice for proper diet is eat real food, mostly plants, not too much.
Yeah. Great. So we do have a very specific question to hypertrophic cardiomyopathy. Gina is asking if these medications are indicated in patients with hypertrophic cardiomyopathy.
Ooh, I don't know that any of these studies specifically focus on hypertrophic cardiomyopathy. So from a pure science standpoint, I can't answer that and say yes. From a kind of how I think about it standpoint, I would think that I would treat hypertrophic cardiomyopathy similar to any other HFpEF and think that weight loss might be helpful. But again, you have to be careful that you don't get too dehydrated in hypertrophic cardiomyopathy, especially if it's an obstructive pattern. So I would speak to your doctor about that specifically.
These are excellent points, Dr. Thibodeau, and certainly it's a data-free zone. So there's also a very specific question about microvascular dysfunction in patients with heart failure with preserved ejection fraction and obesity in relation to microvascular dysfunction and in HFpEF in general.
I guess I could delve into that a little bit. There is an association between HFpEF and obesity as described, and there is an association between obesity and coronary microvascular dysfunction as well as, and so to the extent that these are overlapping conditions, we would expect improvements in functional status and quality of life of patients who can lose weight who are obese with both of these conditions.
Excellent. And one question about exercise, and I know you have shared data earlier about the data for exercise for heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. So this specifically about starting exercise, what kind of exercise is safe for someone with heart failure?
I would lean on the information that we have from earlier clinical trials. So HF-ACTION is the largest scale trial for heart failure with reduced ejection fraction. And that was a moderate to actually fairly high intensity aerobic exercise strategy for patients that had heart failure with reduced EF. And it was demonstrated to be both safe and beneficial for those patients. There is no large-scale clinical trial that shows similar data for heart failure with preserved EF, but there are several other experiences. Most of these tend to orbit around the strategies that cardiac rehabilitation programs offer, which is structured aerobic exercise, usually using devices like treadmills or exercise cycles, but certainly merely walking outside or walking in a climate-controlled environment is a way to start. And then use of light weights and doing some resistance exercise is also a part of those programs and should be also emphasized. We would like to have some further data about the role of physical therapy and exercise interventions in patients with heart failure and preserved EF. And in fact, the ongoing trial Rehab HFpEF is looking at the efficacy of a multidimensional intervention for these patients. And we hope to have data from this that may indeed lead to the ability to get Medicare coverage for patients that would like to do physical therapy and rehab who have heart failure and preserved EF. I wish we all had physical therapists or personalized trainers to work with. That would be the best thing, but aerobic exercise scaled to the patient's physical abilities is the place to start.
And I would add that whatever exercise you like to do is what you should do, because the most important thing is to do it. So if you like to walk, walk. If you like to ride a bike, ride a bike. If you like to do, the elliptical, do that. And start off with what you're able to do. If that's 10 minutes, you do 10 minutes. And then maybe the next week you do 15 minutes. It's not a comparison for you against anybody else. It's just getting in the work. And what I counsel my patients to do is do until you don't feel good, and then do a little bit less the next time. As far as lifting weights and kind of that kind of thing, especially if you're worried about having not enough, do recommend not lifting things that are too heavy, because when you bear down, that puts pressure hard and makes it a little bit harder. So that's, again, something to talk to your provider about, so that you can get individualized information, what's best for you.
This is great. Thank you for making it so practical. So we're going to take 2 more questions before we conclude this session. We have a question about whether losing weight can actually improve the heart function.
I will start with that there are data, particularly for patients who have had bariatric surgery and lost that large amount of weight, who started off morbidly obese, that there is improvement in cardiac function and metabolism of the cardiac myocytes. And so in brief, yes, that the cardiac muscle cells can operate better and show a metabolic profile that's healthier for the long run with large-scale weight loss. And the data for that is strongest in experiences with bariatric surgery, which is, again, is a large-scale weight loss opportunity that that we are only now beginning to be able to start to touch with pharmacotherapy, as Dr. Thibodeau highlighted.
Right. Great.
There has not been much looking at these medicines and heart function. There was one study that looked at this medicine and heart function, but it was a short duration of follow-up and didn't show much benefit yet, but we really don't have much data to say one way or the other yet.
All right. So our last question is basically tying it all together. And this question is asking about the role of different specialists. With endocrinology, kidney specialists, heart failure, including physicians, advanced practice practitioners, and also pharmacists and medical nutritionists in helping achieve weight loss goals. So what is the role of this interdisciplinary team in caring for our heart failure patients?
Well, that would be fantastic if everybody had access to this multidisciplinary team. In the real world, it probably don't have access to all of that. And so while I think that that's most beneficial, and I think if you had that, that would be fantastic. Not everybody gets to have that. I think working with a dietitian is fantastic. And working with your endocrinologist, if you have diabetes, is essential. Working with whoever's taking care of your heart failure is also very important. And if you have kidney disease, working with your kidney doctor is also important. Whether that's all into one group probably isn't going to happen very often.
Yeah, I couldn't agree more. I think you, especially if you are considering pharmacotherapy interventions for obesity, finding a person that will help you champion that and working with that person, whoever that might be. And I'm sure that you would agree in practice that there are people that you've taken that step to do, but there may be other people who have a primary care physician or an endocrinologist that's willing to take that step. Yes. As long as you can identify that individual that will help, utilize that individual, work with them, and work from there.
And along those lines, it does not need to be the cardiologist or person managing the heart failure. It really could be anybody who can prescribe these medications to help.
Very well said. So basically, leveraging your local expertise and whoever is your champion, follow that. Well, with that, we're going to conclude our session for today, obesity and heart failure. Thank you to our speakers, Dr. Vader and Dr. Thibodeau, and thank you to our sponsors, Merck, Abbott, AstraZeneca, Novartis, and Novo Nordisk. And most of all, thank you to our patients and their caregivers for joining this webinar. A reminder to our attendees to visit the virtual booth OnDemand, and also please make sure that you join the HFSA. Joining the HFSA is free for all our patients and our caregivers, and it's a great way to stay informed with helpful heart failure resources. Attendees, please complete the survey, and this will be sent in the email shortly following the webinar. Thank you so much.